As a background introduction, I am a professor in the Department of Radiology at Stanford University. My lab works on developing a lot of in vivo assays to study various cellular signal transduction networks. And we also develop a lot of therapeutics like targeting microRNAs, and we develop suicide gene therapy as a cancer therapeutic applications. And we also work on developing a lot of imaging assays to study how the immunotherapy responders can be identified from non-responders. So my association with Sam started in 2001, I think, when I came to this country for the first time, and I had to join in his lab at UCLA as a visiting scientist. He came to, I still remember actually, for the first time he came to airport and picked me up, and he had a nice house, pre-furnished, and at the UCLA campus. And it was like a kind of a long memory. And he also convinced me, originally I had a plan of going back after 2 years, but he convinced me to stay here, and he kind of motivated me to how important this molecular imaging actually, how it can help patients in translational applications. That all made me to stay in this country. Now, he's like a kind of more than a mentor. Sam is a kind of very kind-hearted person. Actually, he can influence. Influence on everyone's life in a tremendous way, like he did on my family as well as my career. And I still remember actually going to his house, and my son like a kind of having a kind of swimming pool with a melon. On all those things are like a kind of long memory. Actually, it cannot be like easily go away from my mind. And with that note, actually, I just want to introduce today's speaker, Dr. Bruce Haffty. Actually, Dr. Bruce Haffty is currently an Associate Vice Chancellor at a kind of cancer imaging program at Rutgers Biomedical Health Sciences, and is also a professor and chairman of radiation oncology at Rutgers Robert Wood Johnson Medical School in New Jersey. And Dr. Haft received his medical school, internship, residency, everything he has done in Yale School of Medicine. Following all his studies, actually, he spent almost most of his career, all the way till 2005, in Yale School of Medicine. Following his movement to kind of Rutgers cancer program in 2005, I think since then he has been developing a lot of different programs in Rutgers, where he is currently actually focusing on studying the molecular genetic factors which can influence on the patient who receives radiation therapy. And is also a leader in several major like a national clinical trials. Actually, he is co-authored in a number of national clinical trials papers published in very high impact journals. And he is currently a co-investigator on several national clinical trial programs funded by NRG and Alliance cooperative groups. And he has been authored nearly more than 400 peer-reviewed articles and 30 book chapters and numerous editorials and letters, and is consistently kind of high-profile clinical physician provider and patient care. And he is a kind of, in addition to spending a lot of his time in the clinical practice, actually, he is also doing a lot of tremendous work in the research on radiation oncology. And he has been like a kind of cited in several different journals and different programs as a kind of leading clinical care provider. And for the over past 20 years by several different journals and publications, like countries leading physicians by Best Doctors in America and Ladies Home Journal and Good Housekeeping America's Top Doctors and Top Doctors of Cancer and Top Doctors in New York and New Jersey area. And he also received like a kind of 2013 RSNA Outstanding Educator Award. And he also received a New York Röntgen Society Distinguished Radiation Oncologist in 2011 and RSNA Annual Oration in Radiation Oncology for 2019. And Norman Edelman Clinical Science Mentoring Award in Robert Wood Johnson Medical School in 2019. And he's also kind of leadership in patient care award in 2018. So with that kind of introduction, without any further ado, I just want to introduce Dr. Haffty, who is going to talk on genetic factors in breast cancer screening and imaging. Dr. Haffty, it's all yours, please.
Thank you for that kind introduction. Okay, so I'm going to talk to you today about genetic factors in breast cancer screening and imaging. I'm really try to talk to you about what's happening now, but also where we're going in the future with respect to breast cancer. For the woman with the average risk of breast cancer, we know that the ACR, as well as the American Cancer Society and multiple other societies, have screening mammography recommendations, which are pretty consistent across the board. Some minor differences between the various societies, but the ACR obviously has, and all of them recognize that, of course, regular mammographic screening results in substantial reduction in breast cancer mortality. So because of this, of course, we recommend annual screening in women age 40 or over. The stopping age is a little variable depending on the patient's health and other factors. We really feel that women should understand the risks of screening, weigh the benefits and the risks, but clearly the benefits are quite substantial in the majority of adult women. That's the average risk woman. However, the high risk woman, which currently is more or less defined as a woman with a calculated lifetime risk of 20% or more, have slightly different recommendations. And those are not only for the routine mammography, but also for MRI as appropriate, MRI in those women, depending on the age of when their relatives were diagnosed. But in generally speaking, MRI in addition to mammogram are starting around the age of 30 to 40. These high-risk women, of course, also include women who had previous chest irradiation, which doesn't necessarily relate to their genetics, and women who had personal histories of breast cancer again. It's interesting that obviously Black women and those of Ashkenazi Jewish descent should be evaluated for a breast cancer risk at an earlier age, so that if they are at higher risk, they can be benefit from the supplemental screening of MRI. However, it should be noted that all of these various risk factors really are looking at one, trying to determine what the patient is at risk for, and also trying to determine if they are a carrier of a BRCA1 or 2 mutation. And in order to do this, really multiple models have been developed, and these models vary in their the various factors that they put into them, but all of them really try to say, okay, based on these factors, we feel your risk of breast cancer is more than 20%, and therefore you should benefit from additional screening besides the annual mammography. The most common, I mean, and all of them are used and all of them are quite reliable, but I'm going to really focus on what's called the Tyrer-Cuzick or IBIS model, which is really probably one of the more robust models, because it not only takes into account a lot of history factors and Ashkenazi Jewish descent, age of menopause, age of onset of menses, etc. It also includes breast density. Now you don't have all of these factors in all of these women, but it's a pretty good and pretty robust predictor of stating that a patient is or is not at higher risk than average for breast cancer. And again, the reason we do this is simply to identify those patients who are at high risk, where they may benefit from MRI. And how do they benefit from MRI? I won't go into all of the historical studies, but bottom line is that in addition to mammography in those women at higher risk, it impacts earlier detection, earlier stages of disease, lower rates of advanced disease, and some studies have even shown overall survival, particularly in those who harbor the very high risk BRCA1 and 2 genes. But BRCA1 and 2 gene testing was really what we were doing 10 to 20 years ago. We still do that, but most women who undergo genetic testing nowadays undergo what we call multi-gene panel testing. And they don't get tested for BRCA1 and BRCA2 alone. They get tested for multiple other genes. There's multiple panels. I won't go into all of them, but suffice it to say that most of them include assessing for the PALB2 gene, CHEK2, ATM, PTEN, P53, and others, because these are clearly associated with slightly higher risks of breast cancer. Not as high as BRCA1 and BRCA2, although PALB2 is pretty close, but they certainly place women at higher risk. The kind of additional information we get from this, however, is we not only get that whether they had a functional mutation, a bona fide mutation in any of these genes, but we get information about they have variants of unclear significance, or polymorphisms that are unclear. And so women and their physicians are really given much information about things that we really don't know what they mean clinically. Nonetheless, this is the standard right now to do multi-gene panel testing. So I just want to give a very, very brief kind of primer on genetics here, which I'm sure all of you know, but just to go over what these mutations are. Of course, in this upper left hand, you see what's called a deletion mutation, where the A is deleted and clearly the protein, which is normally here, saying hist all the way across, gets changed. We have insertion mutations, which again will change the protein. We have sometimes frame shift mutations, where it starts reading one beyond where it should be, and clearly this protein is vastly different than this one. And we have nonsense mutations, such as this one, where instead of a CAG, you get a TAG, and that says to stop. So clearly these proteins are different. Whether they are functional or not, or whether it causes a disease state or a problem with whatever that function is, can be quite variable. But clearly these kinds of mutations change a protein significantly enough that it could cause a change in the function. More commonly, pretty common, is what's called single nucleotide polymorphisms, which is just a replacement of a single nucleotide. So here, C is replaced with A, and that changes one amino acid in this, which may or may not change that protein, probably doesn't change the function that much. And you got to remember that patients are either homozygous or heterozygous. So even if there's a change, and going back for a second, even if there's a significant change in the function of the protein from one of the genes, the other gene may be perfectly fine and produce the protein and not impact function at all. In fact, most BRCA1 patients are heterozygous, and even though BRCA1 has a lot to do with DNA repair, their DNA repair for the most part is pretty much intact because they're heterozygous. So one of their copies of genes is really functioning quite well, and the other copy may be not functioning, but they do fine with the one copy of the gene that's producing the protein normally. So just to go over a little bit of glossary, so we have deleterious mutations, which means It's like a BRCA1 or BRCA2 deleterious mutation results in a given phenotype. We have variants of unclear significance, which, given more and more data, may or may not pan out to be significant, or they may just be polymorphisms. The majority of variants of unclear significance are probably just normal variations that don't cause any problem. We have the polymorphisms, which we think are normal variations. And again, a patient can be either homozygous, where both copies of the gene are impacted, or heterozygous, where only one copy. An example of a disease where, or ATM mutations, which are often heterozygous, generally patients do quite well. They don't have any different phenotype than anybody else. But if they are homozygous for an ATM mutation, they have a significant disease with significant sensitivity to radiation. So these single nucleotide polymorphisms are interesting. If you look at the literally millions of nucleotides in our DNA, they randomly occur that you'll have polymorphisms in either 1 in 100 to 1 in 1,000 base pairs. And these variations are really what accounts for our genetic variation. And so most individuals are actually 99+% identical in terms of the DNA. We all have to make insulin. We also have to make hemoglobin. We all have to have certain functions going on. So most of our DNA is pretty identical. And that 1% is what makes some of us look different. Some of us have different characteristics, etc. Those are the single nucleotide polymorphisms. An interesting paper in Science many years ago, which showed that these two dogs are actually 99% identical if you sequence out their DNA. But a polymorphism, or actually probably a functional mutation, functional change in the insulin-like growth factor gene, results in high levels, which are seen in large dogs, and low levels, which are seen in small dogs. Yet they are otherwise 99% identical. Dogs and wolves are also about 99% identical. And as much as we perhaps don't want to admit it, most of us are in fact 99% identical. See all these leaders in the field here, and although we all have very different characteristics and personalities and appear differently, we are about 99% identical. And although we're 99% similar, all of these polymorphisms, insertions, deletions, and other mutations clearly result in us having distinct phenotypes, unique susceptibility to disease, and unique responses to treatment. And the underlying genetic makeup of the individual can not only influence how we appear, but it influences our breast density, the risk of tumor development, the response of tumor to treatment, response of normal tissues to treatment. One thing that we are doing right now in my laboratory, we collected about 1,000 patients who were treated with radiation over the course of the past 20 years. They have at least 5 to 10 year follow-up. And we are looking at specific outcomes in terms of toxicity. And we are sequencing approximately 6,000 genes to try to determine whether polymorphisms or any genetic changes are associated with adverse outcomes or positive outcomes in patients undergoing radiation therapy. Now, I said to you earlier that patients routinely undergo multi-gene panel testing, not only BRCA1 and 2, but all these other genes. And when they do that, and when you look at genetic causes of breast cancer, you see that BRCA1 and 2 really account for, and these other high risk, account for only a small amount of what we call familial breast cancer. The other 80% may be attributable to combined polymorphisms, and people have done this analysis of the polymorphisms. They call it a polygenic risk score. And what's interesting is that there are 2 ongoing trials in breast cancer screening that are looking at testing age-based screening versus risk-based screening. One's called My Personal Breast Cancer Screening, and the other is screening depending on breast cancer risk. But the idea is to look at group of polymorphisms and determine whether or not that patient may be at higher risk. A paper that was published in JNCI recently actually did an interesting study. This was not, clinically relevant yet, but they divided patients into a number of polygenic risk scores based on polymorphisms, et cetera, in these various high-risk genes, and came up with a screening recommendations, which was perhaps more cost-effective and more effective by taking the high-risk group and doing very intensive screening, and the lower-risk group and doing biannual screening, or even they claim no screening, which probably won't happen. But overall, the study demonstrated that compared with the general population guidelines of looking at just age, if you tailor risk based on a polygenic risk score, you may identify women at higher risk and have a better impact on treatment. And again, the possible impacts everything from imaging to susceptibility to age of onset to how we manage patients. As I mentioned in our study, we're trying to look at how these genetic variations may impact on skin reactions, toxicity, local recurrence, et cetera, after radiation. Now, you all know about breast density. It's a significant risk factor. But the other question is, are there likely genetic determinations of breast density? And a number of studies have looked at this. Here, obviously breast density is multifactorial, but it also can be influenced by polygenic or changes in polymorphisms in genes. And these are just a number of studies that have looked at that. One of the more interesting ones I thought was this last one here, identification of 31 loci for mammographic density, phenotypes, and their association with breast cancer. Because we know breast density is associated with breast cancer. We don't think it's causal necessarily, but it's associated with it. Can we find the polymorphisms that actually lead not only to increased breast density, but increased risk of breast cancer? Now, I'll end with this final note. This is called MARI, which is a mammography-based breast cancer risk model. Now, what this study did is they took mammogram image and put it in an image encoder, looked at it in women, and in addition to the traditional risk factors like a Tyrer-Cuzick or IBIS risk model, wanted to see whether this gave added value to the risk. And in fact, it did. In an initial study, which they published in one of the science journals a few years ago, they did the image encoder, they put it in, used AI to look at the images, added that to the risk factor, and then developed a hazard ratio. And then more recently, they did a nice study where they validated this in multiple hospitals throughout the world, showing that there was added value to the AI-based mammography interpretation in addition to the typical risk models. And so this was a study published in JCO in 2021. And basically what it concluded was that it increases accuracy across globally diverse test sets. So there were a lot of ethnically and racially different women in these studies. And it has the potential, I wouldn't say to replace current risk models, but to supplement risk models in making guidelines for MRI screening, offering broad and equitable improvements in care. And so it was a large study across multiple institutions in the world. And we would hope that this would, in fact, impact ultimately. How I see that, they used a single mammogram in the AI interpretation of a single mammogram. I see this evolving over time to taking women multiple mammograms over 5 years or 10 years, looking at subtle changes that the human eye may not be able to pick up, but that AI can, and then looking at risk based on sequential AI interpretation of mammograms and adding that to the risk models. But you can imagine a time when we have personal family history, we have genetic testing, panels, polymorphisms in multiple genes. We use artificial intelligence, guided mammographic interpretation, incorporating not only one mammogram, but a series of mammograms. And maybe we can get to the point where we could say, these are very low risk women, maybe every other year mammographic screening, to a very high risk that need twice yearly mammograms and MRIs. Whether we get to that in the next few years, I don't know, but I think this is the direction that things are going, where we're using both genetic factors, polygenic risk scores, as well as AI and mammography to determine genetic risk. So I thank you for your attention and open to any questions.
Thank you, Dr. Haffty, for a great presentation on how the radiation can influence on the breast cancer, as well as how they are influencing on the screening and imaging. And since we are running out of time, actually, they are just telling me to kind of catch up with the time. So I don't see any question in the Slido. So I will stop with one question from me, actually. Can you quickly comment on how this mammography-associated radiation can influence on the patients with familial breast cancer?
I'm sorry, the question was how the
mammography-associated radiation can influence on the familial breast cancer.
Yeah, I don't, I mean, the data we have so far is that the mammography itself, which is very low doses of radiation, doesn't impact. However, having said that, when I talked about the polygenic risk scores, you can imagine that maybe there's a sequence of genetic changes which put patients at higher risk for radiation-induced cancers. Where maybe that would come out. But right now, you don't see mammography itself, even though there's a lot of fear of radiation among patients. The doses, the risk benefit is clearly in favor of doing mammography with and the low doses do not impact. But I can imagine that there are genetic changes in some individuals where maybe that's a factor. We just aren't there yet.
Okay, thank you so much. Thank you for the great talk. I think Dr. Brain will come back after the break. I think we have a break till 2:30 p.m. And Dr. Brain Sumit will come back and introduce the next speaker. Thank you so much. If you have any question, directly email to the speakers. And with that, I will close this session. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.